2 minutes past 1. So, Fatmata, if you want to go ahead and kick off with our introduction, then we can go ahead and get started.
Thank you very much, Tiffany. Good afternoon, everyone, and thank you for taking your time to join this provider forum today. It has been 8 months since we launched the bundle, and thank you for sticking in there with us and bringing us what you're finding, helping us address the growing pains. And we do appreciate all the work that you are doing and will continue to do so and be available to you, whether it is during your one-to-one questioning or even asking questions during this forum. Just want to make sure that we continue to keep this door open. So at this point, I will hand over the forum to Tiffany to continue with the agenda and presentation of the information. Thank you. Tiffany, over to you.
Thank you. Let me just adjust my screen sharing real quick. Okay, can you guys see my screen okay? Okay,
Yes.
perfect. Thank you. All right, welcome everyone. Just wanted to kick off with our usual ground rules for our provider forum. So first and foremost, this meeting is being recorded. It'll be posted to our DSS YouTube channel. We'll also be distributing these slides and posting them on the DSS website, so you have access to all the information that we're about to cover. If you're not speaking, please mute yourself for minimal disruption. And then you're welcome to use the chat for any Zoom technical or audio issues. There is a Q&A feature where you can raise your hand to ask any questions. The Q&A feature is going to be found if you click the more, there's a circle with 3 dots in it, and you can find it that way. In terms of our agenda for today, there's 3 quick things we want to cover. First and foremost, wanted to share a reminder about the doula care add-on payment opt-out and the family medicine attestation forms that are due next Friday. Main bulk of the presentation is to review the quarterly quality reports and answer any questions that you guys may have about the reports that were recently distributed earlier this month. And then finally, we wanted to give a preview of what the case rate refresh process will look like in anticipation of year 2 case rates. So diving into our first section, first and foremost, wanted to give a reminder in response to provider feedback, maternity bundle practices have the option to 1, opt out of receiving the doula care case rate add-on payment, or 2, or you can also include your family medicine providers in this program if they do provide maternity care. So at this point, you should have received 2 forms. They're separate forms from your CHN Provider Engagement Services representative. If you're interested in pursuing one or both of the options, you should submit and sign both forms to your CHN PES representative by September 5th. Your decision will be reflected when you receive your final performance year case rate prior to go live. In terms of the doula care add-on payment, it's been a while since we've last talked about this, so wanted to just remind providers about how this option looks like. So if providers, basically through this program, on top of your case rate, practices will be receiving an add-on payment for doula care and also for lactation supports. For doula care, that's a $14 monthly add-on payment on top of your case rate, and that's provided to practices that are partnering with doulas and offering doula supports. If you are not interested in contracting with providers, you have the option to opt out of receiving this $14 per month add-on payment. If you do receive this payment, it's going to be subject to a retrospective true-up process to ensure and we're identifying the actual amount of doula services being provided during the performance year. DSS recognizes if providers want to minimize the administrative burden as part of the true-up process, you don't intend to contract with doulas in year 2, you have the option to opt out. So like I said before, there should a form that you should have received from your CHN PES representative. So go ahead and submit that form. If you're interested in opting out, I'll note in our appendix, we do have a couple slides with more information about doula integration and the doula care case rate add-on payment overall, if you are interested in learning more about this process. And then as a reminder for family medicine inclusion, this was an update that DSS made earlier this year in response to provider feedback, recognizing that some family medicine providers do render maternity care and they are embedded on the maternity care team. So for those practices who have this kind of setup, we wanted to provide the opportunity for them to be included in the program, for them to receive the case rate, and those costs be included in the reconciliation calculation at the end of the program year. So similar to the doula care opt-out form, there's a separate family medicine attestation form saying my family medicine providers do render maternity care. DSS is going to do a case-by-case review, and we'll make that approval based on the attestation and our review findings. That form, again, should also be submitted next Friday by September 5th. And now moving on to the quality reports, I'll pass this over to Sean from our Mercer team.
Great, thank you, Tiffany. You can go to the next slide. So up to date, you should have received two quarterly report publications, one in April and one in July. We want to remind you that if you need guidance or questions, to please email the Maternity Bundle PES email, which you see on the screen, or you can contact your practice's PES representative. Going forward, in addition to, going forward, DSS will share the data reports on a quarterly basis. You can expect to receive that third report October 31st. What I did want to highlight based on some practice feedback is in addition to your own individual practice dashboard information for the quarter, you will also receive the aggregate quarterly data for the same period. At this time, that we felt this was probably the best way to share more information, because there was a request to share just all practice information, but de-identified. But with the data sets being so small still, and with the fact that we only have 1 month claims data lag in each quarter, we didn't think that that would be really helpful or meaningful, and it's not as valid or statistically significant. But we do want to make sure that you have additional information to really start to support how you're looking at your data and decision making within your practice. So you will see, as we go into the third quarter, both that aggregate set of data, which you'll see on the next couple of slides in a moment, as well as your own. So I just wanted to highlight that. So that's going to look a little bit different going forward. So if you can go to the next slide. This is a reminder of what the reports reflect. So as I mentioned, you have two different lags. You have a 1 month claims lag and a 1 month processing lag. Each quarter is a rolling year to date basis. And when we look at the following slide in a moment, I will highlight what you should have seen that looks slightly different from a trending perspective. The table below helps to remind you, based on these lags and that rolling basis, what months would be included in each quarterly report. So the report you just received in July captured January, February, March, and April. Going into October, it will add May, June, and July. And again, this is rolling because as we add each additional month, we have more run out that gets added in. And ultimately, our full picture wouldn't really come until we go into 2026 to capture the full amount of run out and lag just in your normal processing. This next quarterly report will also have 3 additional dials on it. So if you are an opt-in practice for doula, you will start to see your data for doula from the encounter forms in this next report. You will also see the behavioral health risk assessment and the breastfeeding measure. So those will be new in your October 31st report. Again, as we've cautioned, this is still a small amount of data. So we really ask folks to look at this data with some caution. And I want to also remind everybody that this does not inform the reconciliation as it stands today. The reconciliation will have the full run out and the full amount of data sets. So I do want to remind folks about that so you're not getting worried or anxious about, well, it doesn't look the way I had hoped. Again, reminding this is a very small amount of data as we incrementally roll out the program. So if you can go to the next slide. So this is the aggregate view of the last period that was including May. So this does also include May, just to give you some additional snapshots, because since we distributed your last quarterly report, we did receive May data. So we're beginning to build May and June into the dashboard that you'll receive at the end of October. What I wanted to highlight in particular that was different in the publication you received in July is this year-to-date measure rate trends plot table. So the dials and the bar graph, those are cumulative with all months, but we thought it would be helpful to start to make sure we're looking at trends. And so on both the performance measure page as well as the reporting measure page, you will start to see the year-to-date measure trends plot chart show each month. Again, as you see on yours, as well as even the aggregate, there is very little movement because we still do not have a significant amount of data. But the idea would be is over time, we're going to look at this by month for now. As we have more data, this can shift to quarterly, eventually annually, but we wanted to make sure that you were familiar with this change and why, and we were really just trying to create a place in which, as more data comes, we can begin to assess trends. So that's why that looked different for you from the first quarter. And then going into quarter 3, the language in the top right in red will be updated slightly. There's some language in here that was creating a caveat for the delay in the encounter data. Now that will be in the information, that will come off for quarter 3. And so you'll see a slight change in that red language just describing what's included or what's coming. So as you can see right now, things are trending fairly flat, and we expected this. We don't anticipate to really see the impacts of the data until we close out the year and have full run out captured. So if you want to go to the next slide, it's similar here for the reporting measure. And we wanted to show you what quarter 3 would look like with the encounter measures. So you'll see that we have the breastfeeding measure, the behavioral health risk assessments, and what the doula dial for those who are opted in. So if you've opted out of doula, you will not have that doula dial on your publication. But for those that are opted in, you will have it added as you see here. And we included May to start to show you what that would look like. And again, as I mentioned previously, we added the year-to-date measure rate trends on the plot chart, and we'll do that by month until further notice to try to really see the data trends, because we don't think doing it by quarterly will be helpful at this time because we have such a small amount of data coming in still. I think that was my last slide, but I just wanted to check if there were anything that came in the chat, or if you want us to keep going, Tiffany, and we'll talk at the end.
No questions received yet, but if any folks want to raise their hand or have questions about stuff that Sean just presented, feel free to do so.
Okay, well, if anything comes up, I know we'll have time later. So in the meantime, I will now pass it over to Caroline.
Thank you, Sean.
Mhm.
So, my name is Caroline Scott. I'm an actuary with the Mercer team, and I wanted to provide an update on how we will be handling the case rate refresh for performance year 2. Before we talk a little bit about the refresh process, I just want to level set on how the PY1 case rates were established. So wanted to note that these PY1 case rates are based on historic episode costs from October 2022 through September 2023. And that does include historic fee schedules and historic acuity. Under the current state plan amendment, there's language that case rates will not be rebased more often than once every 12 months. As we look at performance year 2, we have some limitations in our ability to capture post-program experience in the case rate because the program did not go live until January 2025. So we have proposed for performance year 2 a limited refresh that will leverage a lot of the work that was done to set up the performance year 1 case rate with some limited updates to reflect current Medicaid fee schedules and current acuity levels for the members served within the practices. There is consideration of additional updates beyond fee schedule and acuity to the rates to recognize other changes in the service environment, but all of those will be at the discretion of DSS. We anticipate that we'll be able to deliver preliminary case rates to the practices for review in the late fall. It is our intention that this will be a process that is collaborative with the practices, and practices will be able to review those rates prior to them being finalized and ask questions and submit feedback as well. So following the delivery of those preliminary case rates, we plan to provide a technical assistance session so that practices may be assisted in understanding how the case rates were updated and give the practices an opportunity to review. And then practices will also be provided with an opportunity to submit written feedback to DSS and Mercer for consideration prior to rates being finalized. And I will pause to see if there are any questions on PY2 case rate refresh. All right, hearing no questions. Tiffany, are there any questions in the chat?
Not related to the refresh, so we can hit those questions after
All right,
the section.
thank you. I'll pass back.
Okay, thank you. And just wanted to give a reminder about some of the resources that DSS has created for providers. In particular, wanted to call out the program FAQ and our code list. We've received a couple of billing related questions in advance of this forum. And so wanted to just point folks to the FAQ and code list. I believe MedOps also has a billing specific FAQ that we can share more information about. But those would be great resources for any questions that come up about billing and payment, as well as other resources related to quality and reporting, and also doula integration. And as always, if you have any questions related to the program, you're welcome to send those over to the maternity bundle questions email or your direct PES representative. So we can get into the Q&A portion of this forum. We have a couple questions coming through in the chat that we can go through. Sean, I think this first one might be directed towards you related to the quality reports. So the question is, can you say more about the low numbers? How low is low? Can you say more about the denominators for the cesarean and low birth weight measures?
Can you be more specific with that question? I mean, depending on your specifics, we might need to take something back. Is it?
I think overall, kind of Sean, to the point of what you were saying earlier in terms of low numbers, this is recognizing just how the data is coming in with the 1 month lag and then the 1 month processing. So in terms of the denominators, we can follow up more specifically about certain measures if there's
Could-
more specific questions there.
I don't know if it's probably easier for me to clarify verbally, if
Yes,
that's
please.
okay. So what's the total number of cases for which case rates are being generated now, the number of distinct, unique pregnancies?
Oh, you're asking a case rate question?
No,
Um,
I'm asking how many patients are so far attributed and for which the providers are being generated case rates. I may have missed this, and apologies if it was covered, but I don't know how many in the first 4 months of data, or yeah, I think it's 4 months. How many cases or how many patients are attributed in the program?
so
Yeah,
I
I think, Sean, Mark is asking just a volume related question.
okay.
And so I know it's roughly 12,000 or 9,000 over the course of a year that would end up being attributed. So it would be a quarter of whatever our total expected attribution is based on historical data. And then that's going to vary by the size of the practice. A practice that sees 3,000 deliveries a year is going to have very different results on a quarter than a practice that sees 30 over a year.
Yeah, so Dr. McGraw, thanks for that. I was interested in, I understand that you don't have much in the way of numbers for individual practitioners or practices, depending on the size of the practice. I guess it could be larger. I'm more interested in this issue of, are there some 3,000, are a quarter of 12,000 currently attributed in the program in this first 4 months? And and then I was interested in the denominator for measures like low birth weight, where it looked like the denominator was 4,000 something, and but I wasn't sure whether that was a screen resolution issue or if I'm missing something in the same. And for cesarean, I thought the denominator was 1,000, so I just didn't understand what those statistics were about.
So that is coming to us from the claims. Those are coming from claims, those particular numbers. And I think your question on attribution then eventually ties it back to case rate and reconciliation. Am I following that right?
Yeah, I'm not so much interested in case rates per se. I'm just trying to get us, you've got a program that is designed to impact the well-being of patients. You've got a quarter of a year of data on patients. You're presenting statistics on things like cesarean rate or low birth weight, and I don't know how to interpret those. I don't know how they're lining up against the program goals. So it's like I see a lot of numbers, but I'm not seeing a lot of insight. And I understand that part of this call is about sort of their administrative questions, such as the next question that Lakeisha Petway has. I'm just trying to get a sense for, you present quality data, so what am I supposed to
Yeah,
do with this?
so I will let me respond to that, and then I'll see too if Fatmata, if you also potentially want to respond, or Caroline, because I saw Caroline's hand go up and down. So I will say that when we were originally rolling out the program, we had hesitation of releasing data too soon because it's not a full picture, right? Which is why, but we received feedback that folks wanted data anyway, like along the way. So that's why you hear me regularly say, here's what we have based on what the claims have come in so far. However, we would caution you to use this data as it exists to determine potential impact and whatnot, because it is so limited and run out. And why you've heard me say in every one of these meetings, and there's the red cautionary language around, we really think a full year needs to go before assessments are made around impact.
So
I
let me
think, I
put
think,
it another, or maybe Charles, you can shed some light on this.
Okay.
yeah, Dr. Schaefer, I think I totally get where you're coming from. And that's a matter of drilling into the specific measure. If we could pull it back up, we could talk about that to see if it was a screen issue or if the denominator just doesn't make sense in terms of the aggregate number of potential numerators over the denominator. So where was that specifically?
So let's take low birth weight. So it looks like the denominator is 4,331, and I would think that there wouldn't be already 4,000 deliveries in the program, and it seems like low birth weight, you only, and I may reveal my ignorance here. So it seems like low birth weight is the thing you decide conclusively at the time of birth. And I don't know how you could have 4,000 deliveries in the program if there's 12,000 a year, and I'm assuming the patients had to begin getting care in January. They couldn't begin getting care, say, last August. So I'm just trying to figure out, Charles, are we talking about 4,300 births? And by the way, that's not a very small number. So it's actually a big number. And it already tells you a lot about, if it's not impact, it tells you a lot about sort of how low birth weight's trending.
Yeah, I think for that particular one, that can't possibly be the number, right? I mean that would project more than the program did last year. So I think we have to drill into that, and I think part of what Sean is saying is that we don't quite know what the numerator is representing yet. But I think we can drill in there and see exactly what that number means. Can you zoom into that for me, please?
Sorry, let me figure out my reshare so that this isn't in present view.
That's okay. I think the upshot there, Dr. Schaefer, what you call that, and I think what we need to go back and do is better define the numerator denominators with some definitions and characteristics,
Oh.
and align that with what we expect to see, what we would think we would be seeing for each of those measures, not just the low birth weight. Unless there's somebody that can speak to it specifically.
Well, I'm just trying to not misrepresent information. We can go back and look at this with CHN because we work as a team to pull this from the claims data and then demonstrate this visually.
Yeah, I think
Yeah.
sorry, Dr. Williams, go ahead.
Yeah, no, thank you. I said I think that would be the appropriate thing to do.
Yeah.
And I really also hear what Sean was saying, because we wanted to be very careful into how we release data this earlier on in the program. But I also hear Mark's point of view. So I think it's worth taking it back.
Yeah, we do need to go back and look at the specifications for each of these measures and see what's included and what's not, and why there's variability in the denominator, because I would expect that the denominator should be the same across all measures, except if there are specific exclusions in the specifications of the measure.
Yeah, and we can relook at the definitions, which goes as a package to the practices with each of these dashboards each quarter, and cross-reference that in our next Mercer CHN meeting.
Yeah, I think it's just definitely worth a look at the qualifier for the denominator there. Paula, I see your hand up.
Yeah, I mean, I kind of flow with Mark in this, that, I know that our group represents a certain percent, right, of Medicaid. And I think from a data perspective, even if we had the prior year that wasn't in the case rate, C-section rate, low birth rate, postpartum care rate, we would at least see if we're moving the needle, right? That's the intention of the program. That you're not necessarily, well, you can compare those apples to apples, right? Some of the measures you can't, but prenatal care, you may not be, because your diagnosis may be in a global, but definitely C-section birth, preterm birth, all of those things would give us a better indication of where we were from a prior year to this year, right? That's the whole thesis of the case rate. And so when when we got our report, our team was confused too about what are we looking at? Yes, it's early data, but there could be a story in here that, can tell us, like, for example, I think it was behavioral health. I'm like, are we really missing that many screens? Are we really missing postpartum care? Those are the questions we looked at in our data. But again, I think, to Mark's point, looking at some benchmarks to compare is helpful.
Yeah, and I think part of this and the opportunity in the forum is to continue to define what the quality measures are going to be used for, how we're going to use them, what we're seeing, if it's going to be year over year, that helps us develop a trend line. That's all part of the narrative and the conversation that's happening now. So I think Sean is trying to caution us not to get ahead of developing what these are good for and developing what these are used for. And I think part of that is, Dr. Schaefer pointing out that the denominator count, if that's
Doesn't make sense.
yeah,
Mhm.
it doesn't quite make sense. But and then we go back and we figure out what the qualifier was for the denominator that got it up to a baseline projected, or even of possible, to see how it got to the 4.3. If it's just pulling everything that we expected in the period instead of those that have attributed cases, deliveries, over last year's, which may be a more appropriate way to look at that particular one. But I think we need to do that for each of the quality measures. And, I guess that's the risk in showing this right now, is we're still developing, how useful these are and where they're useful. So bear with us as we do that. We're trying to do that in a interactive and inclusive way. So just bear that in mind if they come out looking a little ridiculous out of the gate.
I did want to clarify, Charles, that these numbers are fairly consistent with what we anticipate would be total births across the practices on or after January 1st.
Mhm.
So I know Dr. Schaefer mentioned that, you're anticipating it would be those who began their care on or after January 1st, but we would also assume that there are some pre-existing members who were receiving care prior to the go live, who gave birth after the go live, that could be included.
All right, keeping us on track with quality questions, I'm going to pull a couple more from the Q&A. Kind of in a similar vein to developing interactively how these reports look like and how the data will be most useful for practices. There's a question of, will you be setting benchmarks for each measure? I believe that's something that DSS and Mercer are hoping to do over time. Like Sean's mentioned, at this point, it's still pretty preliminary, but I'd expect maybe, once we have a full set of picture with the full claims run out, that's something that could be developed, but probably not within the scope quite yet of these quarterly quality reports. Sean, feel free to correct me if there's anything else you want to add. Okay, we had some more questions about the denominators, so we'll make sure to dig into those and review the quality specifications and provide more clarification there to clarify any confusion. There's a question about reporting for lactation. How are you reporting lactation? Most hospitals have a lactation team and we do lactation visits. I believe we'd have to double check the specifications so we can provide a follow-up there. But if the CHN or Mercer team have more insight, you're welcome to share.
Can you make this smaller back to where the way it
Yep.
was? Sorry.
No, you're good. And I think lactation would be on the next slide.
Yeah, so
Sorry.
that's okay. So that should be coming from the encounter form.
I don't have anyone on the CHNCT team that can speak specifically to the lactation, but Kelly, we can bring that back and answer that question for you, okay?
Yeah, that should be coming from the encounter form. So we can put that also on our CHN Mercer agenda to see how that's coming through, which there is a bigger delay, I will say, on the encounter form measures than the claims measures.
Okay, we have a couple questions related to billing. So the first question we received is, should we be billing global delivery charges at all at this point now that the global care is essentially being billed and paid for through the new case rate program? So at this point, you should be billing just the delivery code by itself. The case rate will be triggered through specific diagnosis and trigger codes. Those can be found in the code list. That's going to kick off your case rate, and then you can drop the delivery only code to indicate delivery claims. And then we have another question for other case rate, for any other case rate included services such as ultrasounds, would these need to be recouped as well before initiating the prior case rate claims? Just to clarify this question, is this for instances where you're going back to where you had previously billed fee for service or global delivery charges, but you need to go back to trigger the case rate claim? Just want to make sure.
Yes, that's correct. Like, we know we have to go back and do a recoup for the global delivery, but those ultrasounds that may have been billed or any other codes that may have been billed that are covered under the case rate, what we need to recoup those is have those recouped as well.
Let me double check if our MedOps team is here. Pat, do you have any insight on this one for recouping ultrasounds related claims and cost?
I was just sending you a message in the chat. It sounds like this was actually a question that CHN was bringing back to a provider that we had actually that was emailed to us prior to the stakeholder meeting. And they may actually be getting back to you. I believe I sent those to Nancy Esposito. But if the ultrasound was performed prior to the trigger visit, the claim should remain fee for service. If the ultrasound or any maternity bundle service is billed after the trigger claim, the claim will zero pay and the case will be the payment. No need to go back. It kind of handles itself.
So
Great,
just,
thanks.
I'm sorry, just to clarify, we wouldn't need to have those ultrasounds recouped, only the deliveries that we had billed before we go back to initiate the trigger claim.
You're going back for the entire delivery?
Yes, because our HM started late with the case rate payment program. So they're going to be planning on doing a rebill project to go back and bill for those prior case rate payments that we didn't bill. That's why they were asking that question.
In that instance, I would hesitate to give an answer just because if the payments have already been made fee for service and you're going back to trigger case rate, I worry that that's kind of a duplicate billing. It sounds, and I may be getting that wrong, but it sounds almost duplicate billing. So I would, if you'd like to email that to us, please do. And we
Okay.
can take a look at what you mean, just because I think I'm seeing it one way, but it may not be that way.
Oh, okay. Got you. Understand. Will
Thank
do.
you. I appreciate it.
Lakeisha, this is Kim. If you want to send me a specific example, I can get that over.
Okay. Thank you.
Thank you, Kim.
Thanks, Kat. Thanks, Kim. One other question, what happens if ultrasounds are performed by a different group like MFM and not the practice receiving the case rate? So we do have the case rate set up in which it could be provided to two different practices if there is a trigger claim. If MFM care is more on a consultative basis and then trigger claim isn't initiated by that practice, that would just be paid fee for service. And then the practice receiving the case rate would likely continue receiving that rate if it's just a consultative care service. Josh?
Related question. I thought I had heard at one point that maternal fetal medicine services were going to be carved out. And that's particularly relevant to us because, as you know, at Yale, we have just one practice and the MFM people bill under the same tin as the non-MFM people. So we're doing ultrasounds that aren't, to your system, look like they're performed by the same practice. And that's because you chose not to use taxonomy codes, use TINs. Did I hear correctly that at some point you're going to go to taxonomy codes so true MFM ultrasounds can revert back to being fee for service?
I can take a first pass at this, and then Mercer, if you guys want to weigh in. So MFM services are included, and DSS is currently assessing the MFM data. Like you mentioned with taxonomy codes, that's something that DSS is looking into, seeing how we can integrate that to recognize MFM services better. I will say the caveat there is the taxonomy information for practices is something that needs to be updated to better reflect if providers are MFM and coded correctly. So that's something DSS is working and hoping to do with practices. So it's still under review. But Mercer, welcome additional thoughts if you guys want to weigh in on this as well.
I can offer a little bit of additional clarification. So in the instance where the ultrasound service is provided on a consultative basis, sort of outside of the normal case rate activity for a case rate that is provided to another attributed TIN, our understanding is that would remain fee for service. That would not trigger another a change in the ownership of the case rate as long as that member continues to receive their care through their primary practice. In the case where a maternal fetal medicine service is provided within the attributed TIN that receives the case rate, that would be considered as part of the base cost in the case rate development. So we do bring in the costs associated with maternal fetal medicine within those TINs. So for example, a member who receives the maternal fetal medicine service from Yale, who's also receiving the plurality of their care through Yale, all of those costs would be included in the case rate development process.
Joshua, would it help if we specifically went into Yale's cases and started to look at those that may be triggering from an MFM visit? and to see if they're
Yeah, I don't want
interpreting
to. I don't want to
their
speak for our billing people to know what's there and what isn't there. But yeah, I mean, I think we're the only practice in the state that's like this, where we have within our tin a low risk practice and a high risk practice. I think everybody else pretty much in the state.
We have MFM in our group as well.
And I'm sorry, Paula, what group?
Women's Health Connecticut.
Health Connecticut, right? But probably not the same proportions as at Yale.
No, but I mean, we've
Probably.
figured out a way to allocate money back to the MFM based on the services.
Yeah.
So if you want to talk to us about how we did that, we'd happy to share that with you,
But see, we also do deliveries, which your MFMs don't.
which we don't. That's right. Yeah,
Right.
that's the
But
only
we
piece
have
different.
people who are coming to us for prenatal care, and because of their risks, require extra imaging and extra testing. That's why they come to us. But yeah, maybe that's better something. I saw Cindy on here, so maybe Cindy and I should get together, Cindy Caution, and figure out how Yale can approach that.
Yeah, and we're more than welcome, a meeting to sit down and talk about the instances and take a look and see what's happening in terms of attributing within the TIN and those services that are offered for attributed patients outside of the TIN, and just make sure that the numbers make sense, that what we're seeing, and that way we have real-time data now that we can look at.
Mark?
Yeah, hi. This, if I can lower my hand. Just with regard to the question that Dr. Capel is raising, we had with Fatmata and back when Dr. Richards was at DSS with Sandy Willett as well, we went through a project to get MFMs identified to basically have taxonomies corrected in the Medicaid CMAP in the network so that would be so that any analysis of MFM utilization would be reliable and accurate, because as it was back in April, it wasn't. There were some OBs or MFMs who were not didn't have taxonomies that would allow their services to be called out. And that is a prerequisite to then doing the analysis of whether you have actuarial sufficiency to set up a separate case rate should DSS decide to do so. And I know there was no commitment by DSS other than that you would take a look at it with us. And we haven't, I think it would be useful if we could compare and look at what you've seen in terms of new the providers who corrected their enrollment to reflect taxonomy. And we can do the same with the MFMs that we're engaged with. And then we can maybe look at whether we're at a point where you can run data. But I totally get that the taxonomy is a prospective thing and not a retrospective thing, and it may take time for claims to process and so forth. So that's just for a little context for those on the call who might be puzzled about this. And Dr. Bell, one of the things DSS did not agree to emphatically, they were not willing to have MFM remain fee for service on all counts. We still differ with DSS on that point, but it's not one that they've conceded on.
And thanks, Mark, for that. Thanks for providing that background. You're absolutely correct. We're still collecting that data. And the last I checked, as far as Sandy is concerned, we don't have enough data yet to be able to do that analysis, but we can go back and check. And like you said, there is no commitment yet. Let's see what the data shows us from then to now, if we have enough, and then we can revisit that again. But thank you for providing the background.
Thanks, Alana.
You're welcome.
We have a couple minutes left, so just wanted to make sure we had the opportunity to answer questions. If not, we can end a little bit early. And like we'd mentioned before, you have your CHN PES representative and also the maternity bundle email, which I'll pull up real quick in case additional questions come up. Jamie?
Hi, the question that we had is after the patient delivers, how long does it take for that maternity bundle payment to be reviewed?
Could you clarify what you mean by reviewed?
So there was a portion in the DSF's maternity website that advised that it would be audited for additional payment if applicable for that patient once they delivered, to see if we were underpaid or if there were going to be retractions after the fact.
And is this, oh, go ahead, Faman.
No, I was wondering whether it's the reconciliation. I'm not sure what, I don't think I understand the question. I'm thinking it's the reconciliation, maybe?
It could be. I can definitely try to look into that a little more. There was just a portion that said that if we were underpaid, that it would be reviewed and we would receive additional payment based on the services billed. So that was just our question.
We may have to go back and take a look. I'm not.
Yeah, if you know the location where that's listed or detailed, if you could point us towards that.
Okay, yeah, I will definitely find that and then reach out.
Thank you. Sheena?
Hi, everybody. I'm actually reaching out here from Day Kimball. This is actually not related to the slide deck here, but I'm hoping for some additional assistance. We're actually struggling with doing some of the billing out of Athena. I was wondering if there was anybody else on the call that is using Athena as the EMR to do the billing on the practice side on this call, and then I could reach out for some assistance. All right, if anybody does have information on it, we're over at Day Kimball and just looking for some additional clarification on the software stuff. So if not,
Sheena, we're on Athena. If you could just put your contact information, we'll get back to you.
Where are you from, Paula?
Connecticut, Women's Health Connecticut.
All right, wonderful. Looking forward to talking.
I just volunteered Yuval and
hopefully it's easier than you think. Thank you so much.
All right, if there are no further questions, then we'll go ahead and end our meeting. Thank you, everyone.